An 18-year-old student has a laceration in both flexor tendons in zone 2 of the right hand dominant index finger due to the broken glass. His primary treatment was direct repair of both flexor tendon, third day post-injury. And he had started mobilization program in the hand therapy. Unfortunately, this did not result in functional pull-through of this flexor tendons. He then underwent flexor tenolysis in an attempt to salvage function, a procedure that was not also successful. He was first seen in the hand therapy and surgery department at 4 months post-operative, complaining of restricted range of motion of the operated finger. At physical examination, the right hand showed no active flexor tendon function in either FDS or FDP of the right index finger. Passive movements are almost full with only minimal flexion deformity at the PIP joint. Sensations were intact. The skin was relatively pliable, soft, considering that he had an injury and a couple of operations. The remainder of the hand was normal. Except for routine radiograph in cases with severe bony injuries or arthritis, there is no diagnosis study needed. Although there is some interest in using ultrasound and MRI to evaluate the flexor tendon system, we don't use these investigations. Patient with injuries with the flexor system, when there is a marked scarring, disruption of supporting pulley system and joint contractures, not responded to therapy measures, often become candidate for tendon reconstruction using a stage approach. These patients often have a history of failed prior surgery with adhesions, preventing tendon gliding after a direct repair or a tendon rupture. At first stage, the scarred tendon is excised and the implant attached only to the distal end is placed in the flexor system of the finger. The implant is, as devised by Hunter and Salisbury, consists of a Dacron woven tape encased in a silicone rubber. The tape gives body to the implant and enhances passive gliding, and further provides a better hold for the distal stump and its attachment to the profundus stump. Joint release, pulley reconstruction, skin revision, and nerve repair are performed at the first stage. Postoperatively, the patient is placed in a passive exercise program to regain joint motion, which allows smooth synovial-like sheath to form in response to the implant. Then comes the second stage, which is performed in 3 months later. The implant is replaced by a tendon graft. At this stage, an intense therapy is initiated. Our candidate was an appropriate candidate for exploration and proposed stage flexor tendon reconstruction. These operations are started under local anesthesia to see whether the repair can be salvaged by flexor tenolysis, or if not, in that case, there is a stage reconstruction which is required first. At exploration, we found that the repair had ruptured and the entire flexor tendon system was involved with heavy scarring. Scar tendon is sharply excised. Pulley destruction was noted at A2 and A3. Generally, all remnants of pulley system are saved, or even scar tissue can be used to support the implant. Every scarred pulley are usually usable over the implant, but in our case, A2 pulley need to be reconstructed. This was done by using a technique where tendon material, which is generally available from the remnant of the discarded tendon, is wrapped 2 or 3 times around the proximal phalanx. In reconstruction of A2, overlying the proximal phalanx, the tendon material is placed around the implant and deep palmar to the extensor mechanics. It is advantageous to carry out the pulley reconstruction over a temporary sized implant, tendon implant. In our case, the A1 pulley was preservable and A4, although scarred, was salvageable. At completion of pulley reconstruction, the sizer implant is removed and a new implant is broken out of its package. Moisture in sterile solution threaded into the flexor system and attached distally to the stump profundus. In this passive program, the proximal end of the implant is placed proximally in the distal forearm and not attached to any motor tendon, but left free in the interval between the profundus and superficialis musculotendineus junction in zone 5 of the distal forearm. At this stage, scar excision and joint release performed, as well as a nerve repair and skin revision as necessary. After the tourniquet is released and bleeding is controlled, wound closure is performed. The wound is dressed and extremity is placed in a dorsal splint with the wrist in slight flexion, finger in flexion at MP joint and extension for 1 week, and at which time passive mobilization program can be started. The interval between the two stages is devoted to regain passive mobility of the joints, while the soft tissue are healing and the synovial-like sheath is prepared in response to the implant. The goal is to grade the finger up to a point where it is acceptable for a tendon graft at the second stage with a reasonable chance to succeed. 3 months is sufficient to allow the sheath to form and the finger to heal completely. Stage 2, 3 months later, is actually a simplified tendon graft. In that little dissection is needed or desired as do a little injury to the new sheath that has been created. Distal and proximal end of the incision are opened to expose the ends of the implant. A long tendon graft is usually needed to bridge the gap between the zone 1 and zone 5, and the palmus longus is usually not enough. The plantar is excellent when available and can be removed through one incision at the medial ankle. If not present, it is not possible to determine this without exploration. Then the use of one of the two extensor tendon is a second choice. In our case, plantaris was used. It is sutured to the tendon implant and drawn into the sheath. The graft is attached distally to the distal phalanx and profundus stump using the bundle pull-out technique and tie over a button on the nail. The tourniquet is released, bleeding controlled, and distal finger wound closed. The tourniquet is reinflated and the proximal juncture performed, in this case using a flexor profundus of the index finger as a motor. The suture technique is interweave as per Pulver Tuft. When reconstructing the ulnar side flexors, the profundus mass of the third, fourth, and fifth finger is usually used to motor the fingers or the fingers being reconstructed. The suture is placed in the fingernail for the post-operative mobilization program. The tourniquet is again removed and the proximal wound is closed. After the dressing is applied, posterior molded splint is made and it is placed in flexion of 30 degrees. The fingers at 70 degrees of flexion at the MCP joint and interphalangeal joint in extension. A protected immobilization program is started under the supervision of hand therapists at day 2 or 3. Immobilization is continued for 3 to 4 weeks and a pull-out suture and buttons are removed at 4 weeks. Active flexion is started at 3 to 4 weeks with blocking technique added as feasible, but not before 4 weeks. Exercises continued for 12 weeks. Full resistance is allowed at 8 to 12 weeks. Generally, patients with good range of motion are protected for full resistance longer as they are more likely to rupture. The patient achieves an excellent recovery in 6 months after the stage 2 tendon grafting. While talking about the complications of two-stage reconstructions, reaction to the implant at stage 1, which creates synovial reaction with the fluid building up in the forming sheath. This is a rare reaction. Synovitis was thought to be secondary to contaminants or breakdown of the distal juncture. The fluid is mostly sterile and is treated by slowing down the passive program. Other problems include infection, which, if not controllable by antibiotics, will require removal of implant and redoing the procedure again. Joint contractures that are persistent after stage 1 need to be treated by hand therapy protocol. After stage 2, problem encountering include juncture ruptures, which are attributable for technical problems, and resistant joint contractures. Rupture of the juncture should be treated by repair as soon as feasible. Although many of these reconstructions go smoothly, the most frequent problem seen is restricted motion secondary to adhesions, which again limit active pull through the tendon graft. The use of trained hand therapists helps keep these problems to a minimum.